Hello, my name is Brittany Ranchoff, and I'm a health policy and management doctoral student in the Department of Health Promotion and Policy. Today, I'm presenting characteristics of women in association with intrapartum experiences by continuity of provider type. First, I'm going to begin by providing a little background information. Continuity of care is associated with increased satisfaction with care, including a positive childbirth experience and better health outcomes. Continuity of care is defined as the process by which the patient and the provider-led team are cooperatively involved in ongoing healthcare management toward the shared goal of high-quality, cost-effective medical care. However, 19% of women have never met the provider who attends their birth, suggesting that many women do not experience continuity of care for childbirth. In maternity care, there might be another distinction, not in terms of the same clinician providing care at different time points, but whether the provider type, such as the midwife or an OBGYN, is consistent. Of important note, previous reports indicate a majority of women always or almost always saw the same maternity caregiver for prenatal care. We aim to identify the characteristics of women who have had different type of provider for prenatal care and birth using the Listening to Mothers in California survey. Additionally, we sought to compare intrapartum experiences of women by continuity of provider type. The data are from the 2017 Listening to Mothers in California survey. This survey is a population-based sample of women who had a singleton birth in a California hospital in 2016. The sample was limited to women who had a vaginal delivery and who had either an OBGYN or midwife as their main prenatal care provider. The sample was limited to women who had a vaginal delivery, as women who are high risk would be more likely to have a cesarean delivery, which would require having an OBGYN as the delivery provider instead of a midwife. There were 1,357 women included in the analysis. A key variable in the analysis was continuity of midwifery or OBGYN services for prenatal care and delivery, which was constructed based on 2 survey questions asking women who their main prenatal care and delivery provider was. Bivariate and multivariate analysis examined characteristics of women by continuity of provider type and the associations of provider type continuity with intrapartum experiences. Analysis were weighted to account for the complex survey design. As seen in Figure 1, overall 74.3% of mothers had the same type of provider for prenatal care and delivery. 4.4% had a midwife for prenatal care, but not delivery, and 21.3% had an OBGYN for prenatal care, but not delivery. Of women with midwifery prenatal care, 45.1% had a different type of delivery provider, while 23.6% of mothers who had an OBGYN prenatal care provider had a different provider type for delivery. Continuity of provider type was most common for white women at 78.8%, 81.4% of women with a bachelor's degree or higher, and 77.2% of married women. These associations persisted in multivariate analysis, with women who experienced discontinuity of care were more likely to be from marginalized social groups. Furthermore, women who responded that it was very important to have the provider type that they had for prenatal care were more likely to have continuity of provider type for delivery, as were women who had a choice about their maternity care provider. There were few statistically significant associations between provider continuity and intrapartum experiences. However, as seen in Table 1, in the multivariable models, women who had an OBGYN for prenatal care, but a different type of provider for delivery had a lower odds of reporting that a nurse or maternity type care provider had handled them roughly compared to women who had continuity of provider type. Overall, findings suggest women with midwifery prenatal care frequently have a different type of provider attend their birth, even among women with vaginal births. Efforts to improve maternity care quality should consider the impact of continuity of care and the impact of provider choice and a woman's preference for a specific maternity care provider type. Thank you.
Wonderful, thank you. It was excellent.
Thank you, Brittany, for your presentation. There are a few questions for you. How did you define marginalized groups? Is the first one.
So it would be of lower socioeconomic groups. So like racial and ethnic minorities, of lower education, not married, etc.
Did you look at differences between health insurance status?
Yes. Mhm.
Did you find any differences?
No, health insurance didn't have any major differences.
Okay, you have one more question. Do you expect any differences in pregnant women's outcome and their continuity of care if they were living in other states besides California?
I would predict that maybe potentially that it could be different. California has but a known really good maternity care system. So it's interesting, even there you saw differences, but you probably would see them maybe potentially bigger in other states.
What are some ways that we could improve continuity of care? Is it helping women to advocate for continuity of care, changes within the system, or something else?
I think a lot has to do with all of those, obviously, but I also do think that choosing a provider would help with continuity of services. So it is known that if you choose a provider, that will continue with continuity of care. So I think that's another aspect that should be considered.
Okay, so we have another question here. Is the literature more about provider type continuity or provider continuity?
So this is interesting because in the maternity care literature, it can be different. And so the literature is mostly in the States is about the continuity of provider, like the same provider, but in which this is unique in general, but in the other countries, when you talk about maternity care, it talks about different switching the provider type from the different models of care. But that's not, none of this has really been done in the maternity care spectrum in the US.
It's more of a comment than a question. It says, it's from Dr. Goff. One would expect more conversion from prenatal midwife to OB for delivery because of complicated delivery. Were you to unpack for the vaginal deliveries, how they may have differed?
Oh, you cut off, sorry.
Oh, I'm sorry. One would expect more conversion from prenatal midwife to OB for deliveries because of complicated deliveries. Were you able to unpack for the vaginal deliveries, how they may have differed?
So we did control for like, we're told that they would have a large baby and other and high risk for like BMI. So we did control for those that they might be at risk for that, that might have had a complication.
Irene, did you already read Lindsay Russo's question?
No, I didn't. We
missed that one.
Oh, sorry. Thank you. Can you describe the sampling process a bit more and how the survey was weighted?
So the sampling was based off the birth certificate files were used for it from the 2016 to image off of that sampling. And the sampling was limited to those who were 18 years and older. And then they oversampled Black women, women with midwifery attended births, and women with vaginal births after cesarean were oversampled in the population, as well as then they weighted based off of propensity scores done for the survey.
Great. I think we're good. Thank you so much.